Today we're going to talk about safe patient movement and immobilization techniques. You're going to learn body mechanic terms, the cause, signs, symptoms, and treatment of orthostatic hypotension, basic principles of proper lifting and transfer techniques, and you're going to be able to explain the 4 different types of wheelchair to bed transfers and explain a standard cart transfer procedure. Hospitals generally have annual mandatory training for safe patient movement and body mechanics. They want to be sure you know how to be safe and not injure yourself or others. There's always the matter of workers' compensation as well. If you are injured on the job, the hospital is insured in case of employee injury. Another thing the mandatory training does is show that you've had the training and know how to use the equipment properly and not hurt yourself or the patient. And while the hospital will take care of your injury, you also have a certain amount of responsibility in your injury for not using proper techniques for safety. Back injuries are a very large part of this training that they're doing now in hospitals. So they spend an awful lot of money on people who are injured in their job because our jobs in the hospital are so physical and physically demanding. With proper body mechanics, the patient transfer is done much more safely for you and for the patient. Base of support, you want to keep this in mind. Your good patient handling techniques will require that you know what your base of support needs to be, where your center of gravity is, and which are your mobility and stability muscles. And this will help you use your body much more efficiently and effectively without injuring yourself. So your base of support is the foundation of your stance. The wider your stance, the better your base of support. So standing on both feet with your feet flat on the floor improves that base of support. Your center of gravity tends to be at about the level of S2, the sacral 2 segment of your sacrum. And it's right in the middle of your body. So everything should pivot over that specific area. So if you have a wide base of support and your center of gravity is stable, then you're going to have a much easier time moving your patients. Always use good posture. It's interesting looking at babies and how they learn how to walk and how they first learn how to get their balance. So the baby squat shows an excellent posture, and it's a very natural position for the body to be stable and balanced. Unfortunately, I think as we get older, we lose this posture when we start to sit in chairs or on beds or at computers or lazing on a couch or whatever, and then our back and alignment gets a little bit out of whack. But if you watch toddlers when they're learning to walk and when they're carrying things, they figure out where their center of gravity is just inherently, so they can balance and squat and turn and bend and hold objects really close to themselves, and the body then works the way that it's designed to. So the muscles that you need to be aware of are the mobility muscles, and they're used for lifting, and those are typically your extremities. And the muscles of your torso are the stability muscles that are used for support. So when you think about lifting, you want to use your legs and your arms more so, and then your stability is going to be in your center to keep your back straight and your to keep yourself from twisting or bending in a way that's awkward and could cause injury. You also need to work in teams, and it's really important that you have enough people for the needs of the patient to get them moved carefully and smoothly. So somebody in this team needs to be the one who takes charge and who gives direction and does the count and determines when you're going to move, how you're going to move to get the patient safely from wheelchair to table, wheelchair to bed, bed to wheelchair, any transfers that you're going to do. Patient positioning considerations. Talk to the patient and explain to them what you're going to do. That way you can find out if they've maybe done this before, like we were talking about with a disabled person last week. Maybe they have a good idea of how to make the transfer more smooth and work best for the condition that they're in. So always communicate very clearly with the patient and let them know what you're doing, and listen to them in case they have ideas on how it might work best for them. Let the patient do as much of the work as possible. If they're doing the work, there's a lot less that you're going to have to do, so you can assist them but not have to fully move them if they're capable of helping you to a degree. Using positioning sponges will also help keep them in the position that you want them in. It really is helpful so that they don't, roll. Sometimes their tailbones get sore on the hard table, so you need to make sure that they're comfortable and do what you need to do to keep them comfortable. The lifting principles. The lifting should be done by bending and straightening of the knees. Your quadricep muscles are your biggest muscles, and they are very strong. And if you can keep your base of support wide and your center of gravity centered where it should be, you're going to have a lot less imbalance on your part, and everyone will be safer in the transfer. Your back will be less likely to be injured as well. Take your time. Don't rush through these things. You need to be sure that you handle your patients very gently. Always let them know what you're going to do, when you're going to do it, and how you intend to do it. Even if they can't talk back with you, if they're listening, at least they're not going to be frightened when you try to move them. When you're performing the transfer, like I said, let the patients do as much work as possible. Before the transfer, be sure you understand what the patient's limitations are. Sometimes they think they can do more than they can, and if you know what their injury or abilities are when you start, then you're less likely to hurt them or yourself. Patient's center of gravity needs to be held close to the mover's center of gravity. So it's a really good idea if you're doing transfer from wheelchair to table or chair to chair, things like that, to use a gait belt or a transfer belt that helps you get a good grip on the patient so you're not fussing with their clothes or slippery fabrics that they're wearing. You've got a good base of a hand support and grip that you can get on the patient. It's a really great tool to use, and you may not have them easily accessible in your department, but ask at the hospital, at your clinic, where they have these belts that you can possibly use to help move the patient. There's a good video on how to use them that I put the link on this slide. Another consideration is any patient who's been in bed for a while, or of course if they're not feeling well, there's the potential for orthostatic hypotension, which is basically the patient sits up and they get dizzy and their blood pressure drops suddenly, and the next thing you know, they faint. So they may have dizziness, fainting, blurred vision, slurred speech. There's going to be several things that might be a clue. But you always, when you sit somebody up, have them sit for a minute to make sure they have their bearings, to make sure that they are not dizzy, that if you can get them up safely and get them back into their wheelchair or from bed to wheelchair, whatever you need to do. So if you sit them up, give them a minute, talk to them while you're making sure that they're fine. And if they do feel faint, don't send them back to their room or the ED, or don't send them back with a transporter until you're sure that they're stable, because you don't want them to faint on their way back to wherever they came from. It's a lot harder for the patient if they're, in a hallway than if you've got them somewhere where they're safe so they don't fall. Another really big problem with patients, especially older patients with a very thin, friable skin, is that it can tear very, very easily. So you have to be careful when you're moving the patients that you check out their skin just to be sure, because even your hand can tear their skin very easily. So I've had patients during barium studies, for example, where they have to roll around on the table and all of a sudden you look down, there's just blood everywhere because their skin tore somewhere on their knee or their leg or their arm. Their elbow is a big area where the tears can happen. And those are really, really hard for the patients to heal from, because you can't really sew them back together. It's just like little crepe paper skin that gets torn. So be really careful to make sure that the patient is well supported and has enough cushioning if they need it when you're transferring them. Wheelchair transfers, there are 4 different types. The really important thing you need to remember with the wheelchair transfers is to lock the wheelchair. If you're getting a patient out of a bed, you need to lock the bed. Make sure everything is locked so it's not going to be moving. There are 4 different types of these transfers. There's the standby assist, where the patient pretty much can do most of the work and you're going to stand and help support them. And then you have the assisted standing pivot, where the patient can't really walk, but they can help you a little bit. You can stand them from the wheelchair and pivot turn with a good base of support and have them sit on the edge of the table and then scoot themselves on. 2-person lift, when the patient is not able to help at all, 2 people can lift them up out of the wheelchair. And most hospitals now have hydraulic lift systems, and that's a really great thing, especially for larger patients. And most of them are motorized. The ones that I've seen are motorized, so you have a remote that you hook the patient into the sling, and the remote, then you can use it to lift the patient. Then you move the device with the patient like on a swing and bring them over to where you want to either sit them in a chair or lay them on a table. And it's so much easier than trying to struggle and injuring yourself or the patient. So if you're doing a standby assist transfer, then you want to make sure that the patient has the ability to get up and turn and sit down on the edge of the table with you standing by in case they need some assistance. If the table doesn't go up and down, you need to make sure that you have a footstool nearby. You don't want the patient to stand up and then realize you need a stool because they can't sit on the edge of the table without a step. So make sure your step stool is nearby as well. Make sure the legs or the feet off of the wheelchair are moved out of the way as well. Don't make it harder than it has to be by not moving fixing the chair so that it's not going to get in the way of getting your patient on the table. You don't want them to trip or fall over something when they're trying to turn. So make sure it's clear by their feet so that they can get up on the table. Use the footstool if you need to. Don't let them hold on to the footstool handle though, because that's just going to fall over. Have them stand up, use the gait belt if you need to, have them turn, and then they can step up and you can assist them. Assisted standing pivot, as I said, this is a person who can't really walk, but they can help a little bit getting up out of the chair. You help them and help them turn and have them sit on the edge of the table so you can get them on the edge there. There's the example. I know this is a really busy slide, but I wanted you to be able to read it on the slide, but it's on page 156 in your patient care book if you want to get a better look at it. And there's also some really great videos on YouTube with how to do the pivot turn with assist with the patients. Two-person lift. We're not going to do this in class, but it's also an option if the patient isn't able to help at all. It tells you how to manage it. That's on page 157. So typically, if you have a patient who is much lighter weight or can't bear weight at all on their lower extremities, this is somebody that you would use this kind of a lift with. This is the hydraulic lift I was talking about. This one looks like more of a manual one, but the ones that I've seen are motorized, which is a whole lot easier to use. Cart transfers. Make sure everything is locked again. Allow the patient to help as much as possible. Usually you need at least 3 people so you can protect the patient's head. You have 2 people on one side and 1 person on the other, so it's a smooth transition. And this is definitely for, you need to use the slide board or a hover mat to get the patient moved over onto the table. You also need that 1 person in the lead again. 1 person is going to determine how the transfer goes, how quickly it goes, who's doing what, just to be sure you're all on the same page and it goes smoothly. So this is a patient transfer with a draw sheet. And I don't know that you want to always do this because the patient, if their back is bothering them or if they're bony on the back, they're going to be really uncomfortable when you slide them from the gurney to the table. You might catch their tailbone, and you don't want to risk any tearing or bruising of the patient. So you want to be sure you use the slide board or the hover mat at your hospitals. It really helps also to use gravity. So if you're transferring from gurney to table, have the gurney just a slight bit higher than the edge of the table so you can slide the patient smoothly, and it goes down just slightly. It's not a lot, it's just a little bit. And then when you move them back from the table to the gurney, lower the gurney just a little bit so it's about 1 inch lower, and then you can slide them a little more smoothly using using gravity a little bit. And the other thing about this draw sheet that concerns me is that the hand grips on the draw sheet that the healthcare workers are using, it should be underhand, because if you have it overhand and your forearms are twisted, you may injure your muscles or your elbows. So your grip should be underhand, holding on to the sheets. This is the hover mat, and I put some links to YouTube for these. I used these last week when I went and did my annual training at Scripps, and I've never seen such an easy transfer than that hover mat. That was awesome. They should have them everywhere. So you hardly had to even move. It was really very little effort to get the patient moved. And I was on the hover mat and was moved that way, and I can tell you it's pretty darn comfortable and smooth to do it that way as the patient, because you don't feel like you're being tugged and pulled really. You're just still comfortable on a mat and moved over to a different surface. And this is a picture of the slide board, and when you're rolling the patient, you roll the patient toward you to get the board underneath and roll the patient back and then slide them across. So the bottom line with all of this is to protect your back and to keep your patients and yourself safe. You don't want to start out your career by hurting yourself because you don't understand how to transfer patients or move patients, or how to use your mobility muscles and your stability muscles. Where is your center of gravity? What is your base of support? So we're going to practice these in the lab next week, and you'll have, I'm sure you've started doing it in the clinics also, but I want to be sure you understand the proper body mechanics and the transfers. The next section is immobilization techniques, and this is going to help with making sure that your patients can hold still. Bottom line is you don't want motion. So you're going to reduce the patient's exposure because you're going to have fewer repeats for motion on your images. And they'll also help to keep your patient still so they don't become unsafe or unstable. And as always with your patients, but particularly with the elderly and pediatrics, you need to build a rapport with them and gain their trust and cooperation. So this is what we talked about last week in patient care, is making sure you communicate with them in the way that they want to be communicated with. Communication, like I said, is key with your patients. So it keeps them calm, it keeps them cooperative, and understand also that motion can be voluntary or involuntary. Sometimes they have no control over any motion that's happening. For example, a Parkinson's patient that has tremors, if they fell and need a wrist x-ray and they can't hold still, you're going to have to figure out a way to immobilize them. And there are a lot of things that you can use, a lot of devices. Another thing to consider is when you're doing pediatrics, you don't only have to connect with the child, but you also have to connect with the parent. You need to explain the immobilization that you're going to use, or the device that you might use, what its purpose is, and you need to be sure to make sure the parent's okay with the use of it. If they look at what you're doing, they may consider that you're being abusive to their child rather than trying to do what's best for them. So we know what that we're doing with these devices, but it looks a little barbaric to the parents and they get a little concerned. So is it immobilization or is it restraint? And immobilization is one thing, and restraints on people can get you into some hot water with the legal end and malpractice concerns. These are some of our devices that we use. You need your positioning sponge, your sheets, sandbags, Velcro strap restraints, head clamps, and some commercial devices, which would be like the cervical collar, the spine board, splints, sheet restraints. Stockinettes is something that they use in when they're casting patients. And tape is your friend. You can use tape for many, many things. So this image up here is the Pigg-O-Stat, and it looks horrible, but it really does a good job. Patients don't like it and their parents really hate it, but they really do a good job to hold the patient still. You can get the best chest x-rays with that device. And I'll let you guys use that in the lab next week. So as far as these devices, it's really important that they be radiolucent, flexible, durable. They help with reproducibility so that you can keep the patient stable every time you use it in the same manner, and that they are safe and they're reliable. Your sponges, can sometimes just help the patient relax a little bit, and they just need a little bit of support. Maybe you're doing an oblique C-spine or L-spine and you're doing it on the table. You need to support the patient so that they don't have to worry about using their extra muscles to hold themselves still. They can rely on that sponge to help them relax a little bit so they can cooperate better. Plus, then you're not going to get motion that you might get otherwise. You can use sandbags to help hold your extremities still if you need to, or to hold the feet turned in when you're doing pelvis. There are a lot of ways you can use your sandbags. I'll tell you, most people don't use the sandbags for immobilization like this, but if you're desperate, it's an option. And here's our tape. If you're going to tape a child, you need to either put a barrier between the child's skin and the tape, or twist the tape over so that the sticky part is out away from their skin so it doesn't stick to their delicate skin. So be aware of that. And with older people as well, if you need to use tape for some reason, if you're doing finger or toes or something and you can't get all the fingers out of the way of the one you're trying to see, if you use tape, be aware of the condition of the patient's skin. All right, this is the stockinette I was speaking of. It's helps to hold the patient still if you need them. I don't know that I would use this on a child, and I have never seen it used, but I guess it's an option if you need it. So once again, with pediatrics, you need to be very kind and patient and honest, and use language that, you know, appropriate for the child's age so that they'll understand and you can get their cooperation. Being frustrated, kids can sense it right away and then they start getting upset. And this is where restraints are not options. You have to get them immobilized, but in a very calm way that doesn't scare them. All hospitals should have department policies and procedures regarding patient and pediatric immobilization. So follow those procedures. And this is another infant sheet restraint. It's very easy for little ones to bundle them up in a blanket or a sheet to keep them still. They're going to feel a lot more safe as well if you bundle them up. We used to call these baby burritos when I was way back when, but because I think that mummification, which is what they call this, is kind of creepy. So you can use this up to kids for up to 3, 4, maybe even 5 years old. That'll help them hold still a little bit better and keep them safe. Here's the Pigg-O-Stat. So you can do an AP and actually the Pigg-O-Stat, or a PA and the Pigg-O-Stat, then the whole device turns and you can do the lateral right away. So you get the PA done and then you just turn the whole device and it just pivots, and then you do the lateral and then you're done and you get them out of there. It can be really, really quick. This is a really interesting device too. We have something similar in the lab, but it doesn't have that octagonal, those pieces on the end that help you turn it in 8 different positions. But it is a board where you can put the patient, and then there's a channel underneath where you can put the cassette. So it holds the baby still, you get them positioned, you get your cassette in the right place, and you're good to go. And it works really, really well. And I'll have you guys practice with that in the lab next week also. Spinal trauma immobilization. You can do the cross-table lateral, AP, and AP open mouth positions for C-spine with the cervical collar, and it won't interfere with your images. You will have, you'll see some of it. It's not completely radiolucent, but it's not opaque either, so you can see through it and see what you need to see. You might have to increase your technique just a little bit. But the one thing you really need to know is you never, ever, ever remove the C-collar without specific instruction from the physician. Never take it off unless the images have been evaluated and the doctor determines that it's safe to take the collar off. You're going to learn this in next semester when you do spines, but and a little bit of trauma positioning. But it's so critical that you don't take that collar off unless the doctor tells you it's safe to do so. This is pretty much the same information we had on the geriatric slide from last week. You have to worry about them falling, and they worry about falling. Communicate with them. Take a little extra time. Make sure they're secure and warm. Be careful, very careful with their skin, and tell them what the goal is so that they want to help you and cooperate. And if you work smoothly and not too fast, they're going to be much more comfortable. Please be sure to watch the videos that I included, the YouTube videos that I included. They were really helpful in showing how to use some of the immobilization devices and also to keep yourself safe from injury. And that's all I have for you guys today. And I will talk to you next week.